the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Greetings to the viewers of PhysioTV. I, Dr. Prajakta Sahasrabudhe, am professor at Sancheti Institute of Orthopaedics and Rehabilitation College of Physiotherapy. As usual, we are bringing you today a unique topic. The topic of today's webinar is rehabilitation of patients awaiting lung transplant. And the topic would be presented by Dr. Shreya Dhake. She is Associate Professor and Head of the Department of Cardiovascular and Respiratory Physiotherapy Department, Deccan Education Societies, Brijlal Jindal College of Physiotherapy, Pune. Ma'am has teaching experience of almost 14 years, and she's a very enthusiastic teacher, and she has an excellent clinical hands. So without wasting time, over to you, ma'am. Thank you so much to be
Thank you,
associated with
Prajakta ma'am.
PhysioTV. And
Thank you. Thank you for giving me an opportunity to share my experience. So should we begin?
yes, sure.
Hello, everyone. We would be starting with the topic prehabilitation for patients awaiting lung transplant. Lung transplant is known as a well-known accepted treatment option for a variety of selected end-stage lung diseases, which improves survival rate and quality of life. Post-COVID, we have been seeing many fibrosis patients, and because of the severe impact of COVID, these patients are now lined up for lung transplant. Apart from COVID, there is a huge burden of respiratory disease patients who have been waiting for lung transplant. Among this, mainly the patients are of pulmonary fibrosis and COPD, which constitute the maximum burden of the patients waiting for lung transplant. The International Society for Heart and Lung Transplantation Registry reports a 1 and 5 year survival rate of 85 to 59% respectively for adult lung transplant recipients transplanted since 2010. Unfortunately, our country has a very less number of donor rate. So the national decised organ donor rate is less than 1 per million population as compared to 20 to 25 per million population in other developed countries. So this makes us understand that there is a lot many patients who are waiting, but the donors are not available. Maybe this is mainly because of the lack of awareness and some myths associated with organ transplant. Indications, let's have a look at the indications for lung transplantation as per as the International Society of Heart and Lung Transplantation. The main indications are mainly for diffuse parenchymal disease like idiopathic pulmonary fibrosis, pulmonary fibrosis in association with connective tissue disease, occupational toxic lung fibrosis, chronic hypersensitive pneumonitis, sarcoidosis, lymphangiomyomatosis, and Langerhans cell histiocytosis. Moving to the obstructive lung disease, in that smoking, mainly patients suffering from COPD, patients with alpha-1 antitrypsin deficiency, obliterative bronchiolitis, chronic asthma, and infective diseases like cystic fibrosis and non-cystic fibrosis bronchiectasis. The third chunk which constitutes for the indication of lung transplant is pulmonary vascular disease like idiopathic pulmonary arterial hypertension, pulmonary hypertension with connective tissue disease, complex congenital heart disease with Eisenmenger syndrome, chronic thromboembolic pulmonary hypertension unsuitable for pulmonary thromboendarterectomy, pulmonary veno-occlusive disease, and pulmonary capillary hemangionomatosis. Let's see what are the contraindications for lung transplant. There are absolute and relative contraindication. The first contraindication, absolute contraindication, is smoking. Someone who has been smoking and like currently smoking can't be taken for a transplant. He has to at least stop smoking 6 months before the transplant. Any psychiatric disorders, chronic and alcohol abuse, non-compliance with medical care, active malignancy in 2 years, morbid obesity, systemic disease, HIV, and progressive neuromuscular disease. The relative contraindications are untreated cardiac diseases, systemic hypertension, mainly when more than 2 drugs are used for treating the hypertension, severe right ventricular heart failure, multi-drug resistance, insulin-dependent diabetes mellitus, symptomatic osteoporosis, musculoskeletal disease affecting thorax, poor nutritional status, and chest wall diseases and steroid dependency. Donor selection criteria as per International Society of Heart Lung Transplant. The age of the donor should be less than 55 years of age. Smoking history should be less than 20 years of age. PF ratio should be 1400 at 100% FiO2, and positive end expiratory pressure should be 5 to 8 centimeter of water if the patient is on any kind of non-invasive ventilation or even the mechanical ventilator. No evidence of aspiration or sepsis, normal bronchoscopy without any significant secretions, and no organisms on donor gram stain of sputum. Now let's have a look at recipient selection. Who all are going to be selected for lung transplant? Anyone who has more than 50% risk of death due to lung disease within 2 years of transplant, if transplant is not performed. High risk or more than 80%, high likelihood or more than 80% likelihood of surviving at least 90 days after lung transplantation, and more than 80% likelihood of 5-year post-transplant survival from general medical perspective, provided there is adequate graft function. Apart from this, age is also taken into consideration when lung transplantation is considered. So for a single lung transplant, the age should be somewhere around less than 65 years of age. For bilateral lung transplant, the age should be less than 60 years. And the patient should have taken conventional medical therapy, which is no more helping the patient. Patient should not be too sick or need to have at least ambulatory with supplemental oxygen. His PFT reports, especially in case of COPD, the FEV1 should be less than 25% of the predicted without reversibility. And if it is an ILD case, the FVC should be somewhere around 50 to 60, should be less than 50 to 60% predicted. ABG should show PaO2 more than 55 mmHg or elevated pulmonary artery pressure with progressive deterioration. Preference is given to patients with elevated carbon dioxide level with progressive deterioration who require long-term oxygen therapy as well as they have poorest prognosis. This was an overview of lung transplant, which patients are eligible and who will be taken up for the lung transplant. So we need to know which patients will be coming to us, what type of patient would be coming to us, and what problems they would be facing. So these patients would be either a COPD patient or pulmonary fibrosis patient or ILD patient, be it any type of ILD, or it could be bronchiectasis patient, or it could be even, for that matter, post-COVID fibrosis patient. So let's see what are the problems faced by them. Any kind of chronic respiratory disease leads to ventilatory restriction, exercise intolerance, difficulty in ADLs, skeletal muscle and respiratory muscle dysfunction, and affection of quality of life. Mainly because of the ventilatory restriction, patients experience dyspnea with activities. This dyspnea makes them more sedentary to avoid dyspnea, producing decreased activity level, and this further leads to deconditioning, aggravating the dyspnea, and patient further reduces his activity level. So overall, these symptoms, all these symptoms which I have mentioned, leads to a vicious cycle of one leading to the other and other leading to the next one. So it's a vicious cycle is set up, and we need to break this vicious cycle from the point of our by utilizing physical therapy. Let's see what happens with the help of what happens in these patients because of the respiratory problem and because of the other problems which arise in this patient. The chronic overload of the respiratory disease puts increased demands on the patient's body. There is increased contractile activity, alteration in muscle tension pattern of tension development, which leads to respiratory muscle fatigue and weakness. Prolonged hypoxemia, inflammatory and oxidative stress, steroid myopathy, physical inactivity, negative nutrition balance, aging, and indirect insult by systemic disease secondary to ILD or even COPD leads to peripheral muscle weakness, which causes fatigue and weakness. So all these things, when they come together, it causes decrease in functional capacity, decreases quality of life, and decreases the survival of the patient. So these are the problems we as a physical therapist need to tackle when we are preparing a patient for lung transplant. How to tackle it? This can be easily tackled by prehabilitation. Now let's see what is prehabilitation. Prehabilitation is defined as a process of improving the functional capability of a patient prior to a surgical procedure so that patient can withstand any postoperative inactivity and associated decline. Prehabilitation is essential for frail surgical candidates facing a major physiological stressor who are at high risk for functional decline and prolonged hospital stay. Prehab prepares patient physically and psychologically for the entire procedure. Usually, these lung transplant patients have a long wait period till they come for transplant. In the sense, there is something called as lung allocation score, which is calculated in this patient, depending upon the severity of the disease, their lab test and diagnosis. Based on all these things, they are given the they are added to the list of the patients who are waiting for the lung transplant. So at times it does happen that the patients are so weak and so debilitated that they are not at all eligible to be in the list for lung transplant. So here comes the role of prehabilitation. So prehabilitation will help this patient to make them physically fit to an extent so that they become eligible to be listed for transplant. Usually prehabilitation or physical rehabilitation in patients who are waiting for lung transplant is prescribed till the patient goes for surgery. Now this wait period can't be definite. At times it could be 3 months, 6 months, a year or two. It is not definite for the patient. So it is recommended that instead of carrying out this prehabilitation just for 4 weeks, 6 weeks or 8 weeks, it is recommended that they carry out throughout the time till they go for transplant. Let's have a look at the goal of pre-transplant rehabilitation. The main goal is to optimize and maintain the status while continuing close monitoring of the underlying disease. Now, the main aim of prehab over here is to optimize the functional capacity of the individual so that they are able to carry out the activities with less oxygen consumption and less metabolic cost. Okay, and prehabilitation will help the patient to achieve this. The next goal is to prepare the patient for pre-operative period. Now, during pre-operative period, there are many things which the patient needs to be explained. Explanation about the cuffing techniques, secretion management, optimal and careful use of oxygen therapy has to be explained to the patient. Energy conservation, pacing of the activities has to be explained to the patient. Perioperatively, what all things the patient is going to experience or what all things he will be having on him, like chest tubes, drainage tubes, incision, all these things have to be explained to the patient in your pre-transplant rehabilitation, or you can also call it as prehabilitation. Also, the most important goal, the third I have listed over here, is psychological support to the patient. This is very, very important. And when a patient has to undergo a transplant, there is a team which operates for this transplant patient. So there is a surgeon involved, CVT, a surgeon involved. Then there is medicine people involved. There are counselors involved. There are psychologists involved, psychiatrists involved. So it's a very long procedure and tedious procedure. So here the main aim is to give psychosocial support to the patient, which is given as a part of prehabilitation. Though this part is going to be taken by someone else, our domain is not over here. Our domain is to optimize the functional capacity of the individual. Now let's have a look at assessments. What all assessments we need to do when we are going to treat such patient. Apart from routine history and investigations, there are certain specific things which we will have to do it. Okay, lab test which will be done, CT scans to know the severity of the disease. Okay, then perfusion scans will be done. In perfusion scans, the patients who are mainly eligible for lung transplant are the ones having DLCO score of less than 40%. PFT has to be performed. For patients, PFT for the patients who are suffering from ILD, especially, their FVC is going to be less than 80% predicted, and with decline in more than 10% in FVC in 2 years. And for COPD patients, the FEV1 has to be less than 25% predicted. So someone who has these kind of reports, they are the ones who are going to be categorized for lung transplant. ABG has to be done. ABG will help us understand the level of carbon dioxide retention, basically, which will be high, somewhere around above 65 mmHg. And also, we will come to know the level of PaO2. 2D echo will be done. 2D echo will tell us the functioning of the heart, and also it will help us to understand the pulmonary hypertension. What is the severity of the pulmonary hypertension? We will come to know through 2D echo. Breath hold test has to be done, and also in case of COPD patient, Board's index has to be done. So Board's index of more than 7, basically, when it is more than 7 to 10, that indicates poor prognosis, and these are the patients with severe grade of COPD who will be requiring transplant. Someone who has 5 to 7 grade on Board's index basically will have good prognosis as compared to more than 7, and they will be also eligible for a lung transplant if their other reports are in favor of lung transplant. Apart from the test which we have listed, coming to our domain, which we will be performing, the test which we will be performing is exercise capacity. Now, exercise capacity is considered as one of the important predictor for waitlist survival of lung transplant patient. Okay, there are several exercise capacity tests which can be performed, but amongst them, the best is 6-minute walk test, which has been considered an valid tool for evaluation in lung transplant patient. And it being a submaximal test, it can be easily performed, no special equipment required. Patient can take pause in between when required. The speed is also decided by the patient. So that is why this test has more is more preferable as compared to the other test. Now, if we have to speak about the other tests, the tests which are there is you can do lab-based test, that is a test on treadmill or stationary bicycle can also be done. The other field test which can be done is your shuttle walk test, incremental shuttle walk test can also be done. But amongst all these tests, the best test which is considered for the lung transplant patient is the 6-minute walk test. This 6-minute walk test. There is evidence available which says that when the 6-minute walk test distance is less than 290 meters, it is suggestive of having prolonged hospital stay and mechanical ventilation. And the chances of patient being on mechanical ventilation post-transplant is going to be higher. Okay, there are several evidences which are available which talks about the use of 6-minute walk test being used in lung transplant patient pre-transplant and post-transplant also. So you can find few of the evidences which I have listed over here. That is the utility of preoperative 6-minute walk test distance in lung transplant transplantation, which was published in ATS journal. Pre-transplant 6-minute walk test distance predicts peri and post-operative outcomes after pediatric lung transplant. Even in pediatric lung transplant, 6-minute is considered to be an invalid tool. Any individual basically who has lesser distance walked on 6 minutes is going to be a morbid for post-surgery. So our aim is to improve the functional capacity, improve the 6-minute walk test distance so that the prognosis post-transplant is good. If 6-minute walk test is not possible, then an alternative to it is 1-minute sit to stand, which can be performed. There is one evidence which I have mentioned over here is 1-minute sit to stand test in lung transplant candidate, an alternative to 6-minute walk test. This article shows that when your patient is severely debilitated and can't perform 6-minute walk test, this can be easily used, and it has been considered a valid tool when not possible to do 6-minute walk test. So this can also be considered. Apart from the field test and other lab-based tests, there are other tests for upper extremity which can be performed. Many of our basic ADLs and instrumental ADLs require upper limb endurance capacity, and none of our field tests gives us the understanding of upper limb tests. So specifically, when you have to do that, you can go for upper limb endurance capacity tests like unsupported upper limb test or 6-minute pegboard ring test can be used. But unfortunately, there is very less evidence available regarding this test being utilized for lung transplant patient. Now, what is going to be the use of this exercise capacity test? From this, we will be able to assess the need of oxygen for the patient. We will get an estimate about the functional capacity of the patient. It can act as an outcome measure pre-post rehab and pre-post transplant also. And this exercise capacity will be used as one of the outcome for exercise prescription. The next assessment which we need to do from the point of view of physical therapy is muscle function, both strength and endurance. Here we have to target peripheral muscles as well as respiratory muscles. So peripheral muscle strength can be assessed by manual muscle testing by using 10 RM or 1 RM, or you can go for an handheld dynamometer to assess the grip force. Similarly, respiratory muscle strength can be assessed by maximal inspiratory pressure and maximal expiratory pressure through micro RPM or power breath devices, which is available. Now, again, utilization of this is going to be to decide the exercise prescription for deciding the intensity. Basically, for when I'm going to go for strengthening program or resistance training for peripheral as well as respiratory muscles. The third thing which we have to consider is physical performance and mobility. There are n number of scales which are available, which will give us the physical performance and mobility of the individual. Among this, few I have listed over here. Gait speed can be calculated or can be assessed. 1 minute sit to stand can be done. There is short physical performance battery test, which assesses 3 components. This is routinely used in transplant patient. Okay, one test which will give you the mobility also, balance also, and functioning of the patient. Timed up and go can be used, balance test can be used, and even Barthel's index can be, Barthel's or FIMS can be used to assess the activity level of the individual. Again, use of this is going to assess the mobility, balance, and physical function. Also, when we are doing the gait test, it will give us an understanding whether the patient, any gait aid is required for the patient, and also it will be utilized for exercise prescription. Also, in this patient, physical activity needs to be monitored. Now, there are various physical activity questionnaires like IPAC, PACE, DASI can be used. Apart from this, pedometers, accelerometers can be used. Or nowadays, our mobile phones, smartphones also have different app which will tell us how many steps we have covered or the patient has covered. Even that can be used as one of the outcome measure for monitoring the physical activity of the patient. Day-to-day physical activity can be calculated through these apps basically, or pedometers. Again, this is going to be used for exercise prescription. The next important aspect which needs to be assessed is quality of life. This transplant patients who are waiting for transplant basically have huge affection of quality of life. So this needs to be assessed, and which can be done by several scales which are available, like WHO Health Organization quality of life test can be used. Health related quality of life questionnaire can be used. Lung transplant quality of life survey, a scale which measures symptoms, health perception, functioning, and well-being can be used. This scale is specifically for transplant patient. SF36 can also be used, and medical outcome study health survey that assesses the 6 dimensions of health related quality of life, like physical, role, social function, mental health, health perception, and bodily pain can be assessed through this scale. Amongst these 5 scales which are listed over here, lung transplant quality of life health related quality of life, and WHO quality of life, and SF36 are the commonest scales which have been used till now for transplant patient. Coming to the most, after we are done with the assessment, coming to the most important aspect, that is exercise training. Now, the main aim of exercise training is to improve the functional capacity of the patient, so that patient is able to carry out the activities with less fatigue and yes, with less fatigue. So looking at the exercise training, there are no definite protocols which are available for patients who are awaiting lung transplant. But the pulmonary rehabilitation guidelines for chronic respiratory disease can be used for these patients as well. So according to those norms, the frequency should be around 3 to 5 times per week for about 8 to 12 weeks. Remember, though I have mentioned 8 to 12 weeks over here, as I have said earlier, the wait period for the patient to undergo transplant can be very long. So it should not be only restricted to 8 to 12 weeks. If patient has finished the structured pulmonary rehabilitation program by going to an outpatient department or hospital for PR, then the remaining part, till he is waiting for the surgery to undergo, he can carry out at home also. He should not discontinue the exercises, because as we know, as we stop the exercises, there is reversibility is seen, and we don't want the patient to revert back to the baseline. Okay, so the minimum frequency required is 3 times per week. Intensity. The intensity is very lower in this patient. You would wonder that I have not put it in terms of HR max or VO2 max or HR reserve. Okay, frankly speaking, it is not possible to train these patients at specific value of HR reserve or HR max or VO2 max, because these patients get fatigued very soon. They reach their ventilatory threshold even before their heart rate rises to the expected value. Okay, so in these patients, we need to monitor the symptoms. Symptoms are very, very important over here. So dyspnea needs to be monitored, fatigue, leg discomfort. Okay, leg fatigue is one of the common complaints this patient complain. Basically, this needs to be monitored on modified box scale to decide. Okay, so when I'm going to use this modified box scale and when I'm training this individual, it should be restricted to moderate intensity, somewhere around 5 on modified box scale. It should not go beyond 5 on box scale. Okay, and also these patients are going to be on supplemental O2 in their waiting list period time. When they are going to be there, they are going to be on supplemental oxygen. So when we are giving them exercises, titration of oxygen might be required. So that this titration of oxygen has to be discussed with the physician, that during exercise, is it permissible to increase the O2 by maybe 1 liter or so. That needs to be discussed. Always these patients will be given adequate oxygenation so that we are able to increase the aerobic capacity of the patient, and we don't want patient to get fatigued and desaturate when they are exercising. One more thing which needs to be monitored when we are giving exercises to this patient is saturation. Saturation level should not drop more than 88 when a patient is on O2. Okay, if you are dealing with a patient who has lower saturation levels, then you need to decide about the oxygen titration with the physician and then go ahead for the exercises. Duration. The duration of the exercises should be somewhere around 30 minutes minimum, going to about 45 minutes per session. Type of exercise, it is recommended as aerobic exercises and resistance training, which we will be discussing. So in aerobic exercises, interval training is more preferred as compared to other exercise, continuous training, basically, because when you are using interval training, it gives them an adequate time to recover back. There are other evidences which are available which speaks about Nordic pole walking. So when that is also one type of exercise can be used when you can add novelty to your exercise program by using Nordic pole basically. So instead of making them walk on a treadmill or level walking, you can add Nordic pole also to, when you're training these patients basically. These patients benefit well when resistance training is given to them. So resistance training can be started somewhere around 50 to 60% of 1 RM. Can be used mainly for lower limb muscles and upper limb muscles. Main focus is going to be on lower limb muscles because these are going to be your ambulatory muscles. Okay. Inspiratory muscle training is also should also be considered when you are treating patients with patients awaiting your lung transplant. So what should be the intensity? The intensity for training should be somewhere around 30 to 50% of PI max. And this training can be done through various equipments which are available for inspiratory muscle training. It can happen through your threshold muscle trainer, or it can occur through your resistive devices which are available for inspiratory muscle training. Apart from this, simple flexibility exercises, stretching exercises can be incorporated in the exercise program. Now let's have a look about the evidences which are available for in patients who are awaiting your lung transplantation. Okay, so the first article is effectiveness of pulmonary rehabilitation in connection with lung transplant in Hungary. In this study, there were about 60 individuals who were taken, and they had given chest wall stretching, chest mobilization was given for about 30 minutes, and the frequency was 3 times per day. And the patient was also given treadmill or bicycle depending upon the comfort level of the patient, and the time duration was 15 to 20 minutes, and it was in the form of some did continuous or some did interval training for about 1 month. Note the time period was very less, only 4 weeks was given to her. With 4 weeks they observed improvement in chest wall flexibility, training tolerance improved, and quality of life also improved. Considerable modifications were seen in chest wall exercises, CAT score, breath hold time, and PFT values also improved. The next evidence or the article talks about effect of 8-week pulmonary rehabilitation program on dyspnea and functional capacity of patients on waiting list for lung transplant. Here, they had given a combination of aerobic exercise program along with breathing exercises. And they observed that there was notable increase in 6-minute walk test distance. That is, from 300 meters, it had increased to 360 meters. And because of this improvement in 6-minute walk test, patients showed clinical improvement in MRC scale and box scale. The next article is about interval versus continuous training in lung transplant candidates, a randomized trial. Okay, this study showed that the 6-minute walking distance achieved similar improvement in both the groups. In pre-lung transplant COPD patient, interval training was associated with lower burden of dyspnea and with fewer unintentional breaks during exercise, but it also results in comparable improvement in physical capacity. So both can be considered depending upon your patient's condition. The next is pulmonary rehabilitation improves survival in patients with idiopathic pulmonary fibrosis undergoing lung transplantation. In this, a combination of resistance training plus aerobic exercises was done, and the protocol which they used was strengthening the arms and legs with initial charge of 30% of maximum number repetition, that is 1 RM, followed by 1 set of 10 repetitions for each exercise. Treadmill protocol was started at 70% of 6-minute walk test distance speed, adding 6 minutes at time until 30 minutes were attempted. Okay, and they found that, and they also increased the speed by 0.3 kilometer per hour. They found that there was significant increase in 6-minute walk test distance, and less time spent in ICU post-transplant, 5 days versus 7 days, and less time spent in hospital, 20 days versus 25 days for rehabilitation, pulmonary rehabilitation group as compared to control group. Lower ICU death rates and higher 5-year survival rate was seen for the patients who underwent pulmonary rehabilitation. The next article is about Nordic walking in pulmonary rehabilitation for patients preferred to lung transplant. So this is nothing but an innovation which is added to walking rather than usual walking. You can give Nordic poles, you can give those poles to the patient so that with the help of those, the patient can walk. And with those poles, there could be some amount of stabilization which will occur and will help them to breathe little bit better because of stabilization. At 6 weeks mark, 11 patients with Nordic walk experienced a substantial improvement in their average 6-minute walk test distance. 7 Nordic walk 12-week follow-up showed that 14 patients improved their 6-minute average distance to up to 374 meters. Whereas the control group didn't show a specific improvement. Rather, there was a significant drop in average 6-minute walk test distance for control group. The PFT values for the Nordic pole group also showed improvement, mainly FVC from 47% to 52%, and FEV1 also improved, resulting a change in mean dyspnea score on MMRC scale. Yeah, that was noted. So even Nordic pole walking can be considered for the patients. The next evidence tells us about the tele-rehabilitation. Now, many times these patients, since I said that the wait time is more and every time it is not possible for the patient to come to the hospital for the treatment. So patients, so they found out whether tele-rehabilitation would be beneficial for the patient or not. And this was explored during COVID time, because during COVID time, as everyone knows, there was a lot of restriction and it was a long period where it was not expected that the patient stays back at home and deteriorate further. So something had to be thought of that, so that we can keep patient active and we can maintain their functional capacity values. So tele-rehabilitation for lung transplant candidates and recipients during COVID-19 pandemic, article which was published. This article showed that amongst 42 patients, 35 patients or candidates agreed that the app helped them prepare for the surgery. Now the study which was carried out in this, they had prepared an app through which they used to provide an tele-rehabilitation. And this app was not only a video calling kind of an app, but it also gave them patient information. It had a log on which the patient had to feed their information about their exercise status, so that they would be monitored and any mishaps or any complications could be avoided. 18 out of 21 recipients found that the app is helpful in their self-recovery. On RAPA, basically Rapid Assessment of Physical Activity Questionnaire, 57% of lung transplant candidates scored as active, which improved to 87%. The study also showed that there was increase in quadriceps strength, which was improved. Okay. So these are the references for the presentation. Thank you. Basically, in this presentation, I have given you an overview of how you have to prepare your patient who is likely to undergo a pulmonary, likely to undergo lung transplant. Okay. Thank you, Sancheti College of Physiotherapy, for giving me an opportunity to share my experience about this topic. Thank you so much. Over to you, Prajakta madam.
Thank you so much, Shreya ma'am. It was indeed a very in-depth overview or analysis of patients who are posted for lung transplant. And I'm very sure you made a very valid point that it is always a team approach, because it is not just about enhancing the functional capacity of the patient, but overall support, whether it is medical support, psychological support, nutritional support. Unless all the personnel are not coming together, we will never be able to achieve that particular goal. But at the same time, because probably in our country, the awareness about organ donation is not that great, and availability of organs is not there. Sometimes the waiting period could be very long, right? When a person is candidate for lung transplant or any organ transplant. In this case, since we are talking about lung transplant, so for lung transplant. So in this long waiting period, uh, is there any bare minimum criteria which I have to achieve through prehabilitation, as in terms of functional capacity, or is it possible even to set up that particular criteria that let's say I have a sufficient amount of time, let me get to this functional capacity so that the outcome after the transplant would be better?
Yes, there are basically. Now, they usually consider that the patient should be able to do their basic ADLs at least. And in terms of outcome measures, if we have to consider, if the subject or the candidate is able to achieve at least 350 to 400 meters on 6-minute walk test, the prognosis or outcome post-transplant is going to be really good. There are evidences which says that when the distance walked on 6-minute walk test is more, then the chances of patient being on mechanical ventilation post-transplant, length of stay in the hospital, and post-transplant survival is higher. That is why an effort is made that during this waiting period, these patients are referred to physiotherapists to maintain their functional capacity, or rather improve their functional capacity if it is very much decreased. Obviously,
And
this won't be true for everyone, because ILD patients, when they are there, their condition is totally different when you compare with COPD patients. So there are going to be some plus or minus to it when we are considering this. But basic ADLs, yes, it is required.
Correct. And as you mentioned, they have a lot of impairments which are there. One of them, they might be on immunosuppressants also to begin with, right? During
Yes.
the pre-surgical period also. Any added precautions or anything I will have to take in when I'm enrolling this patient into rehabilitation?
See, mainly they are started with immunosuppressants just not when they are in waitlist period, but post-surgery immediately they are started with. But as they are on corticosteroids, as we know this, our respiratory disease is being managed with corticosteroids. So there are high chances of developing osteoporosis. So with respect to that, we need to take more precaution when we are giving any resistance training specifically, or if we think of giving any high impact activity, which is really doubtful to be given in this patient. But yes, we need to be more cautious with respect to osteoporosis in this patient when we are giving resistance exercises.
Correct. One last question. How do you involve caregivers into this rehabilitation, and what will be the role of caregivers into this?
The role of caregivers is very, very important in the patient, for the patient who is undergoing or will be undergoing transplant. Now these patients are basically, because of the chronic disease, they are less motivated, or kind of they would be having certain some amount of anxiety and depression also. So it is the caregiver who is the main support pillar, who will be behind the patient to perform the exercises and motivate the patient for doing the exercises basically. Also, the caregiver should understand the entire procedure. It's not a one-day thing that the patient undergoes a surgery and he will be better in 8 days or 10 days. It's an entire process. Even post-transplant, it takes about 1 year for an individual to get back to its original status, I would say. right? So a caregiver should understand that his role is going to be major role in motivating the patient and providing care to the patient during this entire period. Without caregiver support, things are going to be very, very difficult.
Correct. So caregiver is also an important
important.
member of prehabilitation and rehabilitation team, I guess.
Yes,
So yes. So on this note, I would like to thank Dr. Shreya again for putting light on this upcoming topic. Uh, um, and Thank you so much for the technical team of PhysioTV, and thank you so much for Sancheti College Management for making this webinar possible. Thank you so much to all our viewers. And on the behalf of Sancheti College of Physiotherapy as well as Physio TV, I wish all the viewers a very happy and prosperous 2024. Stay tuned for more interesting topics. Thank you so much.